Okay, today's topic is pleura. So we want to learn more about pleura, what it is made up of, what are its functions, and what are some of the common conditions associated with it. So first thing first, the definition. So pleura is a double-layered membrane, and both lungs are enclosed in it. And to explain the concepts, I've tried to make a sketch from this chest X-ray. So this outline is the outline of lungs from this chest X-ray. The initial division of lungs is based on physical boundaries created by pleura. And to keep things simple, this is how the lobes of the lungs are usually represented, but in reality there is more to it. So this is a right horizontal fissure and this is right oblique fissure. Thus, right lung is divided into three lobes: right upper lobe, right middle lobe, and right lower lobe. And on the left, there is no horizontal fissure, so this is oblique fissure. So this is left upper lobe and this is left lower lobe. This line represents the retrocardiac area. So this is left heart border, which is this, and this is retrocardiac lung, which is visible from behind the heart. If you look at the side view or the lateral view as it is known as, this is the front part of the body or the anterior aspect of the body. This is the back side of the body or the posterior aspect of the body. You can see this is right upper lobe, this is right middle lobe, which is anterior to right lower lobe and is triangular in shape, and this is right lower lobe. You can imagine on chest X-ray that although this is right upper lobe, you're also looking at some of the right lower lobe which is behind the right upper lobe. So this is right upper lobe, but this is the area where you should expect to see some of the right lower lobe. This is right middle lobe, but you can also see that most of the right lower lobe is posterior to the right middle lobe. So you're also looking at some of the right lower lobe which is superimposed by right lobe, and this is definitely right lower lobe, this area, without any superimposition of any other lobe. So pleura not only marks outside boundaries of lungs, it also makes these fissures. The boundaries divide lungs into smaller lobes, and I'll use the right lung only in this video, and it will become much easier for you to understand the left-sided anatomy as well. So pleura is a serous membrane. A serous membrane is a two-layered membrane. It is an airtight, smooth, shiny, and a transparent membrane. It is lubricated by a fluid which is derived from serum. That's where the name serous comes from. And for those who do not know what is serum, it is a fluid which comes from blood. The outer layer of pleura, which is attached to thoracic cavity, is known as parietal pleura, and the inner layer of pleura, which is attached to the lung parenchyma, is known as visceral pleura. So these boundaries are also known as interlobar fissures, and each fissure has its own name, as we discussed earlier. So these fissures are actually invaginations of the visceral pleura. The word invagination is defined by the dictionary as the action or process of being folded back. Okay, so the action or process of being folded back to create a pouch or a cavity. And you can see that this arrangement not only makes pleura a double layered membrane, it also creates lobes of the lungs. Visceral pleura is reflected back at the root of the lung to create the outer layer of pleura, which is known as parietal pleura. And only visceral pleura is folded to create upper, middle, and lower lobes. The fissures are not always visible on chest x-rays, however, they are frequently visible. You'll never see and almost never see an oblique fissure on a PA or an AP view unless there is a pathology such. You'll frequently see oblique fissures on lateral views, and you'll frequently see right horizontal fissure on the AP or a PA view. So this is a chest x-ray, and this is a coronal reconstruction of the CT scan of chest from the same patient, and for the sake of video just ignore these arrows. So we are discussing only pleura. So you can see a dome shaped white line. This is a double layered visceral pleura, the horizontal fissure which separates the right upper lobe. So this is right upper lobe definitely, and this is right middle lobe. And I don't know if you can see a blurred horizontal line here, opaque line, semi-opaque line. This is right oblique fissure on the coronal reconstruction. So because this is at an angle, this is comparatively straight, so you can see a straight line, and this is at an angle, so that's why this oblique fissure is blurred. This is much sharper in shape. So this is right horizontal fissure, and this is right oblique fissure. So this is right upper lobe, this is right middle lobe, and this is definitely right lower lobe. Although I might be going a bit beyond for the target audience, very young people who want to make a future in medicine, but for those who might be interested or already have some knowledge, I want to continue this video for a bit longer. Parietal pleura is attached to chest wall, diaphragm, and pericardial sac. Thus, parietal pleura is frequently named according to its associated anatomical region. Costal pleura, for example, is the part of the parietal pleura which is attached to the internal surface of the sternum, costal cartilages, ribs, and sides of the thoracic vertebrae. Mediastinal pleura is part of the parietal pleura which is attached to the mediastinum. It also forms the pulmonary ligament inferior to the hilum of the lung, which provides architectural support to lungs. Diaphragmatic pleura is part of the parietal pleura which is attached to the diaphragm. Cervical pleura is part of the parietal pleura which is attached to the root of the neck somewhere here. Okay. And you also need to know about pleural recesses. So right and left pleural recesses. Right and left costodiaphragmatic recesses are slit-like spaces between costal and diaphragmatic parietal pleura. During inspiration, lungs descend into the right and left costodiaphragmatic recesses, while during expiration the lungs move up. Okay, just to finish the video, we just want to discuss a few common conditions of pleura, a few conditions only. So pleuritis. Pleuritis is the inflammation of the pleura. Pleuritis that involves only visceral pleura cannot cause pain because the visceral pleura does not have nerve fibers of general sensation. Pleuritis which involves the parietal pleura causes sharp local pain and referred pain because the parietal pleura is supplied with intercostal nerves and phrenic nerves as well. Pleural plaques are common in people who have had exposure to asbestos in past. What you are seeing here are calcified pleural plaques, and you can also see some calcification under the diaphragm just here as well. The plaques, if not well calcified, can sometimes be mistaken for consolidations, but these are within pleura and not within the lung parenchyma itself. Axial CT scan of chest showing malignant mesothelioma. It's a very serious pleural cancer, also usually caused by asbestos inhalation, and these people also have calcified pleural plaques. So these plaques are within the pleura, and the pleura that should be paper thin is, you can see, is beaded in shape, and it's it's very thick, a few centimeter thick on different locations. It's a very serious condition. All right, a chest X-ray, and on your right hand side you can see there are no linear markings. So this is a normal lung. You can see vascular markings going through the lung parenchyma and air spaces. On this side there are no vascular markings, and there is a piece of parenchyma that seems to have some blood vessels going through it, and there is a small outline here. This is a typical picture of a pneumothorax. So pneumothorax occurs when pleural cavity gets ruptured and air enters into the pleural space, which is otherwise airtight. So on a normal chest X-ray you cannot differentiate between parietal pleura and distal pleura, but if the pleural cavity, the pleural space has air in it, and the lung, this is lung, this is whole right lung which is compressed and squeezed because of the pressure of the air within the pleural cavity, you can actually see, you can tell that this is visceral pleura and rest of it is parietal pleura that is attached to the thoracic cavity, and this whole thing is air within the right pleural cavity, and when it happens whole lung will collapse because it's just one cavity. So this is the lung only that has some blood vessels passing through it, and as you can see, because the lung is collapsed, it won't be able to provide, it won't be able to function, it won't be able to provide oxygen to the blood. So the ballooning effect, as I said, ballooning effect of the air compresses lung parenchyma, forcing it to shrink. The lung loses function of gas exchange and fails to provide oxygen to the blood. The pneumothorax can be caused by ruptured blebs. It can be because of trauma, accident, car accidents, stabbing wounds like a knife stab injury, surgical interventions such as biopsies, and a number of other reasons. Although most people don't even hear about it, but it is a very common condition in hospitals that doctors have to. Let me show you another example. This is left-sided pneumothorax. Okay, so this is collapsed lung, and in this example you can see the trachea is shifted towards the right side, and this whole thing is pneumothorax. They come in all sizes. Pneumothorax can be a very small pneumothorax, can be as big as this one. So this is the collapsed left lung and trachea, and the heart is shifted towards the right side because of the pressure of this air in the pleural cavity. And this one can be life-threatening, can cause tension. This is known as tension pneumothorax, when important organs are compressed. Okay, so the major vessels are compressed here, and patient, this can cause sudden death. Okay, the video, I couldn't finish this video without mentioning the pleural effusion because it is such a common thing. So as a result of a number of conditions, people can accumulate effusion within the pleural cavity, which is dependent. Okay, so this is a chest X-ray from same patient. This shows totally normal left lung here, and as a result of a number of conditions, I said, people can accumulate fluid within the pleural cavity, and when it happens, it falls towards the cavity. The patient is standing, and you can see a line, a straight line, a horizontal line, and there is some fluid within the cavity. Okay, so this is left costophrenic angle. So this fluid is filling up the part of the costophrenic angle, and this blunting, okay, blunting of costophrenic angle and this end-root level, this is pleural effusion. And there are so many conditions that can cause pleural effusion. It will take me probably a good amount of time to discuss the conditions that can cause pleural effusion, but this is how the pleural effusion shows. So this is how a normal costophonic angle should look like, and this is how the pleural effusion will represent. Again, pleural effusions can be very big, and can be as small as this one, or even smaller. And I think I should finish this video now. Thank you very much.